Now, a quick word about my evolution and thinking of treatment of stress urinary incontinence. Of course, we all know that the gold standard treatment is the full-length retropubic sling that we have the most long-term data about. However, when we do look at carefully at the Cochrane analyses of patients undergoing retropubic versus transobturator slings, we consistently see fewer complications in the TOT group, but a consistent higher rate of thigh or groin pain. So, what could we do to continue to enjoy the safety of a TOT approach without having the thigh or groin pain? And that's really where I think the advance of single incision slings has made some significant strides. Way back in 2014, the ContraSure needleless single incision sling made by Neomedic was compared to a full length TOT sling. And what they found was that there was no difference overall in the efficacy, and there was a higher rate of thigh and groin pain in the full length TOT group. We've subsequently had the recent publication of the phenomenal landmark article in the New England Journal of Medicine in the UK comparing a full length retropubic sling to a single incision sling, showing no difference in efficacy at 3 years after surgery, but a 14% rate of thigh or groin pain, with 5 tapes needing to be removed, all for pain in the SIS group. And so the question really comes, is the single incision sling emerging as the new gold standard treatment for stress urinary incontinence? And is there anything that we could do to improve on that thigh or groin pain in the single incision slings? Because we know the most common issue that we face, of course, with mesh is the risk of litigation regarding pain and complications relating to the tapes. In the United States, what we have available for use in terms of single incision slings is the Neomedic Needleless device, the Solix sling from Boston Scientific, and the Alta sling from Coloplast. And we can see when we compare these devices that they're quite different. This is the only needleless anchorless device. The Solix is the shortest sling, and the the Alta sling is the one that is adjustable. But both the Altus and the Solix have a barb anchor that goes into the obturator internus muscle, whereas this device from Neomedic has the same concept as the full-length retropubic sling that is just embedding into the muscle without the use of an anchor that could theoretically be a contributor to long-term pain. So what I'm currently really interested in, we just finished randomizing for a large multi-center trial of women undergoing concomitant prolapse and stress urinary incontinence procedures. We randomized patients to retropubic versus concomitant single incision sling, and I'm very, very eager to analyze those results that we hopefully will have within the next 12 months. But I'm really interested to investigate the hypothesis that an anchorless mini sling would have a significantly lower rate of thigh or groin pain compared to one of the anchored single incision slings. So that's what I'm going to be working on in the next several years. Thank you so much for your time, and I look forward to answering any questions that you might have. Auf Wiedersehen.
So let me ask you a question. Your approach to stress urinary incontinence is more or less the same as my approach. That when the woman is young, then I do always a retropubic tape, and if she is older or she has some risks or so, I do a single incision sling. But up to now, I always do a single incision sling with an anchor, and I've got the impression that they have groin pain just as much as you do classical TOT. Is this your impression as well?
Your insight is very strong, and I think that having materials that, anchor in and go through the muscles of the inner thigh is a risk factor for groin pain. And I do think that the randomized trial that was done in the UK comparing retropubic to single incision slings where they used an anchor did find that. It's not universally present, but it is certainly a concern. And so this is one of the reasons why I'm interested in evaluating this very specific question I want to do a prospective randomized trial where we compare an anchorless single incision sling to an anchor-based sling and specifically look at pain. I think that we've demonstrated efficacy of an anchorless single incision sling. And so now the question is there a significant difference in pain?
There was one question from the online community. I think that you are very young. You might remember that we had the TVT Secure. And when we started, with the TVT Secure, we all were very excited and said that's a solution to our problems. And then it failed in the majority of patients. So, what is the difference between this single sling and the TVT Secure?
They're profoundly different. You know, the TVT Secure was an anchored product. You know, it's had those horrible barbs that went behind the symphysis. So to my mind, it was really the same concept of, you know, a full-length retropubic, but just trying to avoid, you know, going beyond the symphysis. The needleless single incision sling, I think, is exactly the same concept of a transobturator sling, but instead of the muscles going through the inner groin, all of the muscles of the inner groin, it's stopping at the obturator internus. And so I think that, you know, that the sling, the way that it sits and the way that it works is different from the TVT Secure. It's really much similar to a full-length TOT, but and I think we've learned that the full-length slings anchor very well with tissue integration into the muscles. I don't think you need an anchor to make them sit and stay. And so, you know, I don't know if stopping at the obturator internus is going to have a different pain profile than continuing all the way through the muscles of the inner thigh. But logically, I would hypothesize that. But, you know, I'm somebody who likes to follow the evidence, right? And I've done this over the years of like, I've got a question about something, I study it. And that's what I'm currently, you know, figuring out how to do a good prospective study on exactly, you know, what impact this would have.
Okay, thank you. Hat es Ihre Frage beantwortet? Ich hoffe jetzt mal, es gab keine Rückmeldung. Rainer?
Well, you said,
Ja, du musst sowieso das, du kannst auf Deutsch oder Englisch sagen, aber ich muss das sowieso wiederholen.
was ist der Cut-off für eine jüngere Patientin?
What is the cutoff for a younger patient?
You know, to me, you know, I don't have an age because you know, like I'm 52, I'm super active. So, you know, like I would like to be considered younger. But maybe somebody in Germany would say I'm already old. I don't know. So to me, it's
Ask
not
my
the
daughter,
age.
she's still 17.
Yeah, it's not the age so much as it is the physical function of the patient and their associated BMI, their associated risk factors. You know, how active do they want to be? So you know, to me, it's there's not an age, but rather the physical activity and the desire for, you know, physical function. And then what is the associated bladder function? Do they have a normal, strong detrusor contraction during voiding? Or are they a dribbler who've got like a lot of high tone pelvic floor and difficulty with bladder emptying? You know, we've learned over the years a lot of those kinds of patients do badly with a full length retropubic sling. And there are a lot of people with voiding dysfunction. So this category of patient, even if they were younger, I would think about trying to, consider a single incision sling.
Is sexual activity something important for you in just choosing the way of a sling? Because if we hypothesize that they have more pain during intercourse when they have a TOT or transobturator sling?
You know, the thing I look for in my exam is the depth of the lateral vaginal fornix.
Okay.
You know, this is something that when people were doing a full length TOT, there was definitely bridging of the sling across the vaginal fornix. And women that had a deep fornix, you really noted that they had this lateral banding. I think with the needleless sling, you know, it goes into the space of retzius and then continues into the obturator internus muscle. So it's not a flat sling that's going into the groin. But that is another thing. I think if we're going to look at pain, looking at sexual function is going to be another important element of that study. But right now, I really do look at the vaginal fornices, and that does influence the choice of sling as well.
Okay. Are there any other questions?
I have a question for you all. What is the current strategy in Germany if a woman presents with who's 60 with primary stage 3A uterovaginal prolapse? What is your current procedure of choice for a patient such as that?
So if you ask the auditorium there, here you will get 55 or 100 different answers. There is no current approach that we can say. So I'm a traditional vaginal surgeon, so most probably she will go out of my office and have a recommendation for vaginal surgery with preservation of the uterus if she doesn't have any pathology of the uterus. But many patients, many surgeons prefer a laparoscopic approach now. But we just had a session in the morning, and there were, I think, 5 different laparoscopic approaches with and without mesh for this kind of a problem. So no answer to your question, I'm afraid.
Isn't it fascinating that on the worldwide stage, we haven't done a good job to really figure out and stratify who is the best patient for the right intervention?
Yes,
So
absolutely.
that's something we have to collaborate on in the future.
I think that was a good word for ending your presentation. Thank you so much for being with us.
Thank you. Have a great weekend, and hopefully I'll meet some of you maybe at the IUGA meeting. So hopefully if I can encourage anyone to attend, I would love to meet you there.
Okay, bye-bye.